Hi, and welcome back to Pallium Canada's webinar series. As you know, I think many of you have participated in previous series. This must be around the 12th or the 13th that Pallium Canada is hosting. And today's is a follow-up actually on a previous webinar that we presented. And so we're really happy to have Dr. Mary Elliott back with us and Reverend Peter Barnes. And the topic is acknowledging and responding to the psychological impact on healthcare professionals of the COVID pandemic. This webinar is supported by an unrestricted grant from Boehringer Ingelheim, the Bridging Hope program, and also with some support from a Health Canada grant. So some housekeeping notes. You'll notice that your microphone is muted. We would ask you to keep it muted as it becomes really difficult. We have several hundred people enrolled in this webinar. So please keep it muted. And if you'd like to connect with us, at the bottom of your screen is a Q&A prompt, an icon. So if you scroll towards the bottom of your screen, you should see a Q&A little box. If you click on that, the Q&A a box will open up, and that's where you can please submit comments at any time, questions, thoughts that come to you. And as the questions pop up, we'll do our best to try and address them. Sometimes it becomes really busy with lots of comments and questions. We'll do our best to address them. But we do follow up at the end of the webinar with a review of the questions that came through, and we send back our further thoughts on those questions if we weren't able to address them during the actual webinar. The webinar is being recorded, and the recording will be made available within a day or two after today. So keep your eyes on the Pallium website for that. I'm Dr. José Pereira, and I'm Professor and Director at Division of Palliative Care in the Department of Family Medicine at McMaster University in Hamilton. I'm also the Scientific Officer of Pallium Canada, and my role today is as moderator. And I'd like to hand over now to our panelists who will introduce themselves.
I'm Dr. Mary Elliott, and I'm a staff psychiatrist at Princess Margaret Cancer Center. I work as a CL psychiatrist, as well as a psychotherapist and mindfulness teacher. Recently, I was appointed to be the lead for staff well-being during the COVID pandemic, and it seems like that's a role that will carry on beyond the acute phase of the pandemic. I'm really thrilled to be here sharing some information, and hope to have a good dialogue with you before we end the session today. Thank you.
And I'm Peter Barnes. I coordinate bereavement services with Eastern Health in St. John's, Newfoundland, Labrador. It's a part of the Department of Pastoral Care, Ethics and Bereavement Services. I have been involved nationally with the Canadian Hospice and Palliative Care Association, and also with the Canadian Association for Spiritual Care. And I have a very special interest in bereavement services and the promotion of grief and bereavement in this country. And as a part of the overall palliative care or palliative approach to care. And it's exciting to be a part of this webinar as well, and to share some, what I think is valuable coaching for people in this very stressful time in how to manage grief and how to see how grief can have a tremendous impact on our lives and positive impact from a spiritual perspective especially. So thank you very much for this opportunity to be a part of it.
Just some important background information. Pallium Canada is a non-profit organization. As I said earlier, it has been and continues to be partially funded through a contribution by Health Canada. It generates funds usually through registration fees of its LEAP courses, and then also through some other products like the Pallium Palliative Pocketbook. I am a paid member, a staff member of Pallium Canada as scientific officer. and our other panelists today don't have any conflicts of interest to declare. We'll now look at the learning objectives for this webinar. And so we are hoping that at the end of this webinar, you'll be able to look at the benefits of using a resiliency framework to cope during this pandemic and to move forward from that. Understand, adapt, and apply elements of team-based delivery using an approach called CREATE, which is a team-based well-being initiative. And then consider the adaptation of the bereavement care approach to the grief response in the COVID pandemic. You will see that we're a little bit touchy with the screen today, so we apologize for that. And you'll also notice that there is a script appearing at the bottom. We're trying that out. You know, there might be some people that perhaps have hearing difficulties. So I'm sure there might be some errors. I just saw quickly that at one point it said that I'm busy preparing pizzas in the background. That's not correct. But let's try this. So handing over now to Mary.
So we thought it would be nice to just take a moment to arrive, to be ready for the presentation. Peter and I both have mindfulness training, and so just to invite you wherever you are, whether you're working from home, you're in the hospital, just to take a moment to take a couple of breaths, breathing in the nourishment of the air and breathing out a softening, an arriving, a letting go. Just repeating that a few times, taking your time to pay attention to your in-breath and to your out-breath. And then I'm going to invite you to reflect for a moment on something that brings you joy, happiness, a sense of accomplishment, success, or just puts a smile on your face. It could be something big or small. Maybe you had a great cup of coffee, or you're in the midst of a great cup of coffee as you're sitting, listening to this webinar. Maybe your garden is looking fantastic. It's not aware of COVID. Just whatever it is. And then I'm going to ask you to open up the chat bar, which is separate than the question and answer box. It's also should be at the bottom of your screen, and just type in, you know, a word or two, what brings you joy. Let's see what happens with that. Oh, nature, family, trees, kids. Look at this, we're going wild with joy. I can't even keep up. Sunshine, dogs, faith. Wow, cycling, dog, lots of dogs, cats, rainbows, gardening, biking, helping others, nature, fresh air, sunshine. Whoa, just take it in. Allow yourself to be aware of all of these joyful moments that people are having. Waterfalls, grandchildren, children. Don't see any homeschooling there. Kayaking, heat. So as these answers keep coming in, music, it's so beautiful. And what I'm going to encourage you to do is, as you move through your days in the coming days and weeks, is just to make room for joy. Remember this exercise and allow yourself to just linger in joy. You see a beautiful bird, you see a beautiful tree, leaves, smile on someone's face, a baby, whatever it is, your dog, your cat, just really notice the joy it brings. Sense into your body. See how it feels in the body to feel that joy. Even doing that now as people continue to share all these beautiful things. I didn't type mine, but my joy actually happened yesterday. I got an early birthday present, and it was the adoption of a cow in Italy, where farmers are having a struggle. One of my kids knows I love cows and saw you could do this, so they adopted a dairy cow for me. So just even stop 4 times a day to notice the pleasant, to notice the joy, take it in, allow yourself to linger with it, and then you can move on to your day. Okay, so I'm going to pass this along to Peter.
Mary, that was really, really very helpful. I'm just going to adjust my camera there for a second. That was really very helpful. And you've provided the foundation for the work that I see in grief and bereavement. And that is to be mindful and to notice our own inner resources. I tell people when I work with them that I get to know a lot of deceased people, and I get to know them really well, and to help people to come to terms with their struggles, their challenges in grief work is quite a challenge. And at the core of it is helping people to be mindful and to practice meditation, and how the inner resources that we have can be so beneficial. The first slide that I want to share is towards reconciliation. And this is a critical one, that this is a goal. The idea that when we are grieving, the importance is to remember people, to realize that we need to develop, to create a new relationship with our loved ones or with those who we are missing. So this slide, it says our loss causes us to grieve. The journey of mourning leads us towards reconciliation with the loved one we have lost. Reconciliation meaning a connection, a sense of knowing that they are all right in death and that this is okay. It's a goal that people, I think, are helped when they identify this as a goal. Stephanie, if you could move on, please. The next is also a critical slide that I use. Oftentimes people, when they are grieving, they think that it has to be one or the other. In other words, many people say, get over it, get on with life, and it's not helpful. There has to be a balance. And I think this is true for the pandemic, especially, to maintain a balance between allowing ourselves to grieve, which is the loss orientation on this slide, and the restoration orientation, which is getting on with life and putting our energy in other activities. And Mary referred to gardens and the joy that gardens bring. Well, that's a restoration orientation. Loss orientation might be to journal to your loved one, or to write some memories. If we are grieving clients in the healthcare system, it might be to write a condolence note. That might be loss orientation, and send it to the family, because you might have memories, especially in the times of the nursing homes and families not able to get to see their loved ones before they die. It's critical that they receive some connection from staff to let them know maybe a memory of that staff has, or you have, of that loved one. And that can make such a difference in people's grief process. So to know that there is a balance, it's a pendulation. We pendulate between loss orientation and restoration orientation. Next, Stephanie. One of the key, I put a lot of credence into what Dr. William Warden, renowned grief counselor, grief therapist, he identifies 4 tasks of mourning. So mourning or grieving is an activity. It's a need, it's a process, it's something that we need to do to help ourselves heal of the grief. And so in all grief, one of the greatest things, or one of the most important things, is to acknowledge the pain. And just as Mary acknowledged the joy, and we need to identify what gives us joy, even gazing around a room and seeing where our eyes pitch, and then just focusing on letting our gut feeling relax and be in that moment is so important. So to acknowledge the pain is also important. So the river of pain crosses our path, the path of mourning, the journey of mourning. It is wide, deep, and so frightening that at times we want to turn around and go back, but we can't, because eventually it will wind around to cross our path again in the future. There's no bridge over this river. We have to go through the pain of grief. And that's why in our healthcare systems, as staff, we also need to be aware of what are our supports, and healthy grieving in the midst of crisis is so valuable. Next, Stephanie, please. The need to transform grief pain. So grief is not something to get over, but grief can be a pathway to new life. I feel that the cycle of life is birth, death, and rebirth. Like our trees are breaking out in leaf, at least they are here in Newfoundland. Those of you in the west of the country have their leaves out for a while and are in flower, but we're just breaking out. And so that's part of the idea that we need to acknowledge that what is the new life, and so to transform that grief pain into new life is very important. So if we can't find a way to make our wounds into sacred wounds, invariably become negative or bitter, because we will be wounded, and suffering is potentially redemptive. All wounds have the potential of sacred wounds. It depends on what you do with them, and this is an important teaching. Stephanie, please. I offer you the idea of being a healing presence, and these are quotes from Miller and about the need for healing presence. How do I become a healing presence? And you can't do healing presence. So at the bed of a dying person, or companioning somebody who's just received a diagnosis, or after a sudden tragic death, how am I a healing presence? How do I bring that sense of peace that Mary helped us recognize, that joy that we felt at the very beginning? How do we bring that to our practice of care, to our clients, to those who are in pain and suffering caused by grief and bereavement? So I encourage that, and it says at the end there, you can encourage healing presence by being appreciative, forgiving, humble, kind, compassionate. And that's a critical piece. The next, Stephanie, please. Why healing presence? Here's what matters: an alleviation of loneliness, an affirmation of one's authentic self, an invitation to wholeness, potential for spiritual bonding, a deeper sense of our common humanity, and so on, a recognition and acknowledgement of the other as person, an invitation to self-transcendence, possibility for greater self-reflection and self-revelation, sharing on a deeper level, a spiritual level. So it's important again to acknowledge how that healing presence is not just beneficial to the clients that we work with, but also beneficial to ourselves. If there's so much to learn by companioning people in their grief and bereavement, by acknowledging their suffering, acknowledging their pain, and encouraging them in their practice of identifying joy and peace in their life. Next, Stephanie, please. living, dying, and renewed, living transformed suffering. Transformed suffering is that's one of the goals again, is that transforming the suffering so that it becomes a resource in a person's life rather than a liability. Next, Stephanie, please. An attitude of healing presence in palliative and end-of-life care and bereavement care. It's an attitude of anticipation that you bring to a relationship. When I work with clients, one of the first things I do is I try to establish the relationship. And one of the ways I do that is being as authentic as I can be and acknowledging their pain, acknowledging that they need acceptance, and the acceptance doesn't just happen in the mind, but it happens in the heart as well. Being transparent that way is very helpful. So that relationship, but I also have to acknowledge that trust has been undermined. When people have experienced a special sudden death, sudden loss, I hear stories of how people are surprised that their loved ones have died, and they haven't had contact with them. There's a client I worked with recently who there was only 20 minutes from the time that the family was notified that the person was now dying, and they rushed to get in. And when they got in, they couldn't see, the whole family couldn't go in, and it was a very, very stressful for the clients. And what I want to point out is that when we experience grief, it's the trust that we have in others and even in ourselves is undermined. So to be aware that when building a relationship, it may take a little while or a longer while to build that relationship of trust, because the trust has been undermined merely by the fact that they've experienced the death of a loved one. Next, please, Stephanie. I like to quote Carl Jung, who says, "The cave is a place of rebirth, that secret cavity in which one is, in order to be incubated, and is open to being incubated and renewed." So the whole idea that the cave, the place of the dark night of the soul, the struggles we have in grief, that is a place that new life, and that we are growing through that ordeal, is a reminder of how this experience of grief can be a transformative experience. So, and I asked the question, can the support you offer help to transform the cave for yourself and for your clients? Next, please, Stephanie. Transforming the pain of grief, fear, and despair. So the ideas of healing presence, listening, vision, or opening space through reflective practice. So as healthcare practitioners, we think of reflective practice, and having an active reflective practice can really help us in our transforming our own pain of grief and fear and despair. The mindfulness that was referenced at the beginning, again, meditation. I often refer people to mindfulness-based stress reduction or others. There was one client I have who I was encouraging in reflective practice and in meditation. And through the conversation, I learned that he has a 45-gallon fish tank, and he sits in front of the fish tank once a day for 15, 20 minutes. And I said, there's your meditation practice. And it helps us settle. It helps us to be grounded in the experience, because some people are truly traumatized by grief. And it's important to practice the trauma-informed care, sensitive to how trauma impacts our grief and bereavement. And that's a vital piece, especially when we're working with people who've experienced death by suicide or tragic accidents. these are words of Henry Nouwen, and I share these with you. And where I am injured, I touch my own heart and my real identity. I surrender the illusion that I am perfectly healthy, strong, and complete. I acknowledge my broken self. This enables me to remain vital and more human, compassionate and gentle. At the sites of my injuries lie also my treasures. That's where I am in touch with my real identity and my vocation. There I also discover my potential. These words are powerful words. I think to be aware that that transformation happens through the grief process can truly be helpful in healing one's grief. Next, please, Stephanie. Compassion to self and others. A quote from Pema Chodron, that as we learn to have compassion for ourselves, the circle of compassion for others, what and whom we can work with and how becomes wider. And I compare this to the metaphor of smoldering coals. And smoldering coals need oxygen, need air, and they burst into flame. And I often use this analogy with my clients to help you to see that opening space to the grief, giving the grief attention, paying attention to what we're feeling and to the feelings that are evoked through a grief process, and practicing the pendulation that I spoke about earlier helps us process our grief. And it helps with the shift in terms of acceptance from the head to the heart. One of the reasons we have funerals and memorial services and celebrations of life is to help people be aware to accept the reality of the loss. But it takes time to accept it emotionally, spiritually, and that's what I call the shift in the heart of acceptance. Next, please, Stephanie. Compassionate communities. I want to draw your attention to the initiative by Pallium Canada for us to create compassionate communities. Our agencies can be, our healthcare organizations can be compassionate communities. Our towns can be compassionate communities. It's that whole practice of encouraging the palliative approach to care, which includes grief and bereavement care, attending to our grief, and encouraging our organizations, especially our healthcare organizations, to be attentive to grief processes, the opportunities for people to debrief and share the pain that they are feeling when people have died, and we have questions and wanting to share the pain we're feeling. So that's a kind of to encourage you to be aware of these resources available from Pallium Canada. Next, please, Stephanie. Suffering, don't turn away, keep the gaze on the bandaged place. That's where the light enters you. And that's a quote from Rumi, but also made famous by Leonard Cohen, of course. And from Tara Brach, when we look directly at the bandaged place without denying or avoiding it, we become tender toward our human vulnerability. Our attention allows the light of wisdom and compassion to enter. Being tender toward our human vulnerability. Again, I go back to the exercise that Mary led us at the beginning, to be aware of how joy can be so close to us just by merely taking the moment even to gaze around and see a beautiful picture. My office looks out onto some trees, and we have wind here quite a bit, and so I often see the trees waving to me, and that makes me smile and feel energized by the energy I see in the trees. Next, please, Stephanie. Grief challenges faced by healthcare professionals. I'm going to list them off for you now. These are familiar to you, I'm sure. The death triggers personal fears or unresolved issues, and that can happen so unexpectedly. To be aware of that. the relationship was particularly close and long-standing. We identify with people's pain and suffering. The circumstances of illness and or death were medically challenging, and that can certainly challenge us. Next, please. The client was seen to be suffering, and that sometimes bothers us. The client's personal circumstances closely resemble those of the healthcare professional, and the healthcare professional feels guilt about some aspect of the client's care, and this often happens in our healthcare system, where people feel frustrated and sometimes guilty and blame themselves when people die when we're not expecting them to die. And these are all challenges that we carry in our grief in our workplace. Next, please. And these are some suggestions for how we practice self-care. And there's lots of literature, and there's lots of encouragement, and there's lots of meditation tools and yoga practices that are available to us that help ground us in our grief, maintain good health and energy levels, understand feelings, to share personally stressful experiences, to have people we trust that we can share these with, or to have a very active journal, to have a very active reflective practice. All of these help our emotions. Cognitively, to challenge our negative thinking, to develop a sense of competence, control, pleasure in one's life's work. Social, to maintain personal support and have a personal support system, and spiritually, to sustain a personal philosophy regarding dying, death, and bereavement. So all of these, to have a holistic approach to our self-care. Next, please. Stephanie, thank you.
Hello. Mary, I was wondering, and Peter, I just saw two interesting comments as you segue over to Mary. One was a question from a participant about chronic grief. Can chronic grief occur? And the other one was a participant who said, Andrea, who had lost her dad over 9 years ago, and the loss is still very much present. And it reminds me of those criteria in the DSM-5 set of criteria around grief. And I've always had some difficulties with that. So maybe if you can just, Mary and maybe Peter, just respond to that quickly, and then we can transition over to Mary's presentation.
I'd like to give attention to the chronic grief. Yes.
Yeah.
Chronic grief, in other words, is complicated grief, and the reality is less than 20% of people experiencing grief experience chronic grief, and this is where we need the resources to help us process, because oftentimes the triggers give us remind us of other grief, unresolved grief. And there are indicators. There are good indicators for assessing complicated grief, and to get the help, individual counseling, but also to be aware of trauma. Grief can also have the effect of trauma, and to be aware of all of the practices that are now available. And that's why I put so much emphasis on having a meditation practice, having a yoga practice, taking care of one's health. All of these help contribute to the processing of the grief, and we can't avoid it. That was one of the first slides I showed, was the importance of the pain, acknowledging the pain. So that's my quick response to that. Thanks, José.
Thanks very much. Mary, over to you.
What I might just add to that is that I'm not sure if you're referring to, from your question, if you're referring to also chronic grief or cumulative grief. And what I notice is when we're not processing each situation of grief that we encounter in our workplace, so I'm even separate from grief outside of the workplace that we may encounter, it begins to accumulate, and it can come out in a lot of different ways. My little story about that is I accompanied my husband to a funeral of a colleague of his, and I didn't know this colleague, and I just started bawling, like crying. And I realized that I had been so busy, and I had had many complicated situations, and a number of young patients of mine had died. And I'd sort of gone from one thing to another. So in the midst of this person's funeral, I was really processing the grief that I was carrying forward from these patients whom I had lost. So I do think it's really important for us to make space for the whole gamut of reactions we may have. So just a few of these slides are similar or the same as what we presented a month ago. But I just thought it was important for those of you who may not have been at the talk a month ago, just to put some context around what I'm going to be speaking about. So I'm calling this, you know, the movement from surviving to thriving. So clearly the literature showed that in relation to COVID, there's significant distress amongst healthcare providers who had been caring for people in China during times of COVID. Those are very high percentages. And there's a lot, right? We're dealing with so many things. I guess in the formatting of this, it got changed a little. This was in sections, but I'll just, when you see the slides, and you will get a copy of my slides, it said individual, and then there was a list of emotional and psychological reactions, and then social and family, and then adaptation and loss. And really, there is so much. I'm going to speak a bit about how we might manage this whole gamut. And obviously, for any of us at any particular time, different factors become salient. And that's at an individual level. At a systems level, there are these issues around communication with a lot of uncertainty and unknowns, especially in the beginning of when we were beginning to cope with COVID arriving in Canada. And the body of knowledge about it, as it changed and as our processes and protocols changed, it made for a sense of distrust or mistrust amongst healthcare providers. And information has been changing so rapidly, and there's been questions about transparency. We've also had to adapt to a changing paradigm from our usual culture of care to metaphors around war, you know, hierarchy, emergency orders, deployment, redeployment. It really has shifted the language that we're used to working with, and it's actually shifted our practice. And that impacts on this other concept I'll be speaking about, which is moral distress. There's also just the change in our physical environments. Some of the physical environments we've heard about, that people are working from home, and maybe it's a little more pleasant, your physical environment. Maybe not if you've got kids who are also needing you and there's no school or daycare. But you know, for some, you've talked about, you know, being able to look at trees or a lake or as you're working. But when we're working within the hospital, the conditions have changed so dramatically. And especially working in palliative and hospice care, it's so different than our usual way of getting close to patients. And there was a question that came up after the last session that I plan to address as we move forward. So the physical environment and how we're working. I know my hospital, we wear masks and shields with any patients that we're seeing. And our professionals, standards or ways of working have really shifted to a language of best practice during COVID, where it's really more challenging to be meeting with families and friends and having families and friends of patients, like when we go in to see people, particularly those patients who are palliative and end of life. The media reports are affecting us, and organizations are sending a whole variety of messages. But given that this is such a busy slide, I wanted to simplify some of what we're going through, and it comes down to this notion of, am I going nuts? And nuts stands for novelty, unpredictability, threat to ego, and sense of control. And you know, the novelty, something we haven't experienced before. Even when you read the literature on COVID, we're talking about a novel virus. The unpredictability, something that you have no way of knowing would occur. And threat to ego, this threat to our sense of competence. Many people are being shifted in the kind of work they're doing and needing to learn new tools and skills. In preparation for a potential surge, there was a group of us who were preparing to do more on the palliative care side, some of the direct palliative care, particularly around goals of care discussions. And that was, you know, really skilling up in that area for a psychiatrist who normally is working, doing other work. And sense of control, those situations where you feel that you don't have control. Oops. So along with these stressors, we have you know, stress patterns, and a healthy stress response, you've all seen this before, right? Our physiologic response is that, you know, we have a stress, our stress hormones go up to meet the demands of the situation, and then they come back down. But what we're seeing with COVID related, pandemic related work in healthcare is chronic stress patterns, where there's repetitive hits, lots of ups and downs of those stress hormones. And sometimes the stress hormones don't even get back to baseline before we're hit again. And so sometimes the stress hormones are going up and staying up. And sometimes we're so depleted because we've been so charged up over so many days and now into months that we remain, there's sort of a flat line, and we're not able to mount a regular stress response. And so it's really important for us to just always be bearing in mind that COVID is a marathon, not a sprint, and to be really caring for ourselves. I spoke about this study a month ago that was done out of Stanford, understanding and addressing anxiety amongst healthcare providers, professionals during COVID-19 pandemic. And in this focus group, out of these focus groups with interdisciplinary teams, what they found was themes of hear me, protect me, prepare me, support me, and care for me, which really helped people know that institutions had to really respond and get access to PPE, to take exposure to COVID seriously, to have access to testing for people, and to look after fundamentals, childcare, and finances and food. And then also around this training around competencies. So our team decided early on, even before this paper was published, that we were going to start supporting teams by aligning a psychosocial healthcare provider to a manager, a clinical manager, and then that person, the manager and the psychosocial provider together, or the supportive care provider, because we included chaplaincy and occupational therapists as well, that they would together plan for what their teams needed. And it really came to fall into these areas and map to these areas very nicely. We were able to really advocate on behalf of these teams. There was, in the beginning, a lot of advocacy, organizational justice. So really making sure that our institution, whatever policies were set, that they were fair and just, that they were equal, like testing and PPE was accessible based on the rules, that we were really aware of moral distress, safety and welfare of both patients and their family members, which led to our hospital being able to secure hotel rooms through generous donations from the public, and that people had the proper training so they felt efficacious, and that there was an ongoing view of how important connection and the fundamentals were. And then there's this area of support me as well around relaxation and restoration, coping with loss, engendering hope, and mental health care. And then care for me came out of, really not forgetting those people who were circulated off work because they had COVID exposures or they developed COVID themselves, and so that we still would remain connected and supportive of them. And so that was how CREATE came to be. And CREATE is compassion, resilience, and team building, so that we were supporting teams. And I would just say that right now I'd like to shift to the heart of what wasn't covered in this article from Schanefeld et al., which is more of around the psychological response. So their support me still remained pretty much at the fundamental level. So with our program CREATE, so compassion, resilience, and team building, as I said, which I co-developed with Madeline Lee, and it's informed by the literature on pandemic response, psychological pandemic response for healthcare providers. Our aim was to maintain and foster workplace, a healthy workforce throughout and beyond the pandemic, and to prevent distress from becoming distress, to prevent stress from becoming distress. And so really we wanted to do this through promoting a feeling of people feeling psychologically safe, and also enhancing psychological safety amongst teams. And that's one reason we had a team approach, so that we could address both simultaneously. It was a way to rapidly implement programs so that people heard about them. We thought if we just sent out emails to help support people, they would get lost in the inbox because we were also flooded. And we also were able to use consultants who had familiarity with the team, so we could really embed the psychosocial consultants, supportive care consultants with these teams. And it was, as I had mentioned before, really we were able to build on previous work such as compassion, presence, and resilience training, a 4-week mindfulness course we offer for healthcare providers, which we continue to offer, and it's actually shifting to an online format. Happy to talk to people about that. And also we had created a program called BRIGHT, Building Resilience Within Institutions Together with Employees. We took this very proactive and preventative approach. I already said we were paired with managers, so that it was like this combination of sharing information and coaching and supporting teams. Through this collaboration, we were able to tailor to the needs of particular teams. So I worked with a COVID unit. I also worked with people who were redeployed and struggling around redeployment to long-term care. And so we were able to appreciate the context within the teams. but no matter what team people were working with, and we had 16 supportive care providers helping, we used a psychological first aid approach to promote safety, to promote calm, to promote efficacy, both within the individual and team. So looking for where they felt efficacious. Remember, stress is caused by the sense of not feeling competent. So really opening to give them space to see where they had competencies, to see where they could apply those competencies in this new world of medicine, and to really bring the teams together. And then also connectedness and hope, which I'm going to speak of in a moment. We were informed by a trauma-informed approach. I mean, this is psychological first aid. And so I'll talk about the polyvagal theory, and also to really be informed by using a resilience approach and coping. We really also were very protective. So we did a lot of advocacy work on behalf of individuals and teams to really restore a sense of safety. And we planned in an ongoing way. So it was like a needs assessment, an evolving needs assessment, because the needs changed, as I'm sure each of you have come to realize. Why resiliency? Well, resiliency is that capacity to bounce back and respond to pressure and unpredictability or adversity in an adaptive and effective manner that leads to learning and positive outcome. Perhaps more importantly, it's not dependent on stress being removed, and it's a great fit for the healthcare environment, which is dynamic and changing. And so we can't take away all the stresses. And so one is able to foster resilience in the midst of stress. It's also an innate capacity, and it's a process, and it can be learned as a skill. So we can foster it and cultivate it. And the rebounding joy exercise is an example of that. Rather than just focusing on the negative, making space to linger also in the positive. And also to move away, it moves into a positivity literature away from pathologizing. It is normal to feel stress at this period of time. And so we wanted to acknowledge that. There is actually a paper that came out that is specific to cultivating deliberate resilience during COVID, which really supports as well what we were doing. In our program, we have 6 domains of resiliency. The rebounding joy is at the top. It's that optimism. We also, at the center, is self-awareness, because we really feel it's so important for people to have awareness of their experience so they can respond to their experience and take care of themselves. And I'm not going to go over all this. But just to say then, around the self-awareness, at the base of our model, we have fundamentals, which are clearly important. We also address perspective, which is where self-compassion and silver lining would come in. Regulating our mood states, really being aware of our mood states is one thing, but then having some techniques to help us regulate through either processing or holding, widening our capacity to do so. I just want to make a point about optimism. Oh, and I'm sorry, there was connectedness there too, which is probably central. Any resiliency program involves support, networks, or what we call connectedness. So important during the pandemic. Optimism, I have a quote from Churchill here about the optimist seeing an opportunity in every danger and the pessimist seeing a danger in every opportunity. And so really optimism ignites resilience through giving energy and power to other factors and to facilitate a creative, adaptive and active coping style, and to broaden our ways of coping. And it's not about ignoring negative or bad things. It's about seeing them, accepting our limits, being future oriented, learning from them. And it relates to happiness, positivity, physical and mental well-being. And concepts like purpose, meaning, gratitude, and awe are a part of optimism.
Mary, sorry,
yeah.
it's José. This is a fantastic webinar. I'm learning so much from both of you. I'm wondering if it's okay with participants that we go an extra 10 minutes. We're going to keep this going because it's just so fantastic, I think. And there's some Q&As coming in. So we will lengthen this if it's okay with everyone. If you have to leave, then we understand, and it will be available as a recording. So let's keep going for another 10 or 15 minutes because this is really brilliant.
Thank you. I'm happy this is going to be recorded. So if you need to leave, you know, please, you can finish the webinar, and please don't hesitate to also email me or email through Pallium. Happy to connect with people. So around coping, so we were talking about optimism, really being able to broaden our ways of coping. People cope in a whole variety of ways. That was one way I wanted to do that exercise at the beginning. In sort of revealing what brings joy, we also see these different ways, these micro moments where we touch into our ways of coping through noticing pleasant experience. It can really settle us. And when we're settled, then we can use problem-focused coping, which is around self-care, fundamentals, psychoeducation, education, and also advocacy. Emotion-focused coping is where we, you know, maybe we can't solve a problem, and there's a lot of emotion that emerges, and it's important to recognize that. Peter spoke about that in relation to grief, and also to validate that it's normal to have a whole range of emotions, and to help people tolerate that whole range of emotions without feeling that they're feeling stigmatized for it. And then meaning focused coping is around purpose, meaning, right? What really drives us, what really gives us, what makes us tick. And for anyone who hasn't seen it, I'd really recommend the Maunder and Hunter YouTube video on coping. You just have to put in Maunder and Hunter and on YouTube, and you'll get this fabulous clip. It got sent out by the CMA. What is really accessible to everybody is the polyvagal theory, which sounds big, but it's actually very simple. And it is a trauma-informed theory that helps us return to a sense of safety. So remember, I said in psychological first aid, we want to first help people find a sense of safety. And it's based on the social engagement system, which is so crucial for us to be aware of when we're experiencing physical distancing. Social engagement is a way in which we cope through co-regulating. So social connection helps us really calm. Somebody in the last webinar asked the question about how do we emanate compassion? How do we connect with patients when we're behind so much PPE? And this theory will help you do that, because if you're regulated, you can help the patient co-regulate as well. It also comes out of the words, the tone, the gesture, and our body language, which still are all present from behind the PPE. Optimally, we want to be in a ventral vagal parasympathetic place, because that's where there's calm, flow, and activation, excitement, exploration, and curiosity is available. When we don't feel safe, we go into fight, flight, freeze, or we dissociate. So we either go to sympathetic nervous system in the autonomic nervous system, or we go into the dorsal ventral system, the unmyelinated part of the autonomic nervous system. And there's ways to get there through grounding, mindful awareness, seeing, hearing, touch, breath, music, you know, having a cup of tea, food, sleep. Another way to look at this is the middle zone here. This is called the window of tolerance. And in the middle zone is where we are socially engaged. We have that nice balance between being alert and energized, at the same time being calm, cool, and collected. What's important here is when that is on, our prefrontal cortex can be online, so we can problem solve, we can reflect, we can use our past experience through working memory, we can use skillful responding, we can regulate emotion. And so we're in a nice physiologic balance. This is a simple concept to teach people. When we're not in this state, we know it because we're either in a hyper aroused state, fight, flight, freeze, or even a cry for attachment, or we're hypo-aroused, where we're submitting, we're collapsed. It's the animal on its back with its paws up. We're numb, we just fold, we withdraw, and we avoid. And so we want to really try and get back into optimal functioning, and we do that through resourcing, through using connection, you know, whether the connection is through phone, social media, seeing people. We do it through food, sleep, mindfulness, yoga, exercise, going for a walk, seeing nature, lots of ways in which we do that. In our resiliency model, connection is really important. And I just want to mention that what we did was when we met with teams, we had people buddy up. So people would ask each other how they're doing. So they were responsible for checking in with each other on a daily basis. I subsequently learned, we published on this actually about a month ago, and another group published something called Battle Buddies. Very similar idea, where Battle Buddies for them is a buddying up system, a little more detail than our how are you doing, checking in with each other, but the same idea. We didn't want anybody to be left behind. And sometimes in a group, people aren't comfortable saying how they're doing emotionally. So this was a way to do it. We also created many opportunities for people to connect, whether it was virtual meetings, virtual coffee time, virtual exercise, music, yoga, cinema. Remembering that people can still connect from behind the mask. I don't know about you, but I am very in tune with people's eyes these days. I spend a lot of time looking at people's eyes, listening to the tone of their voice. And we encouraged teams and group and using social media for the good, virtual groups. Mindfulness is so important, and you'll see this is a slide that simplifies all of the ways that mindfulness is evidence-based. It enhances awareness, it decreases reactivity, so that so that triggering, right? We can also, I showed you the window of tolerance, we can widen the window so that we don't flip into fight, flight, freeze quite so easily, or we don't go into fold so easily. Mindfulness is one way to help with that. Mindfulness also helps us enhance self-compassion, decrease rumination. So if you're really like ruminating about a patient or ruminating about fears of contagion, it helps us decenter so we can see things from a wider perspective, and it builds connectedness. One of my last slides is just around this issue around moral distress. And this has been something that I've been monitoring in the teams that I work with at the hospital. Moral distress is often described as that psychological disequilibrium associated with failing to follow through because of institutional constraints. It also is when we have forced to act in a manner that contravenes our personal and professional values. We were seeing a lot of moral distress amongst our door screeners because they would have loved to allow visitors into our hospital. We're used to having people come into our hospital with partners, and this wasn't allowed. So this was really a place where we intervened to help them hold to recognize this was moral distress and to help them hold it. I myself had a sense of moral distress after I helped prepare a team go off to work in long-term care. And what they met at long-term care was really challenging. And I kind of had this distress that I participated in sending these people off to work in a workplace setting that wasn't really consistent with how they were used to working. We were able to solve that through advocacy and through awareness. So it's really important. We can mitigate effects by being aware of it and having protocols, having group debriefs, etc. And it's associated with burnout. And we use from the Bright program, and I've included a whole lot of short practices for you to see. You just have to pick up one of these cards and you can go with it. So whether you're dealing with grief, moral distress, or some sort of other strong emotion that's triggered, these practices are micro practices that take about a minute or two, probably a minute, and you can just guide yourself through them. Similarly, we have practice that was really helpful for our door screeners, for example, when they had to deal with the anger of disconnection. When people were coming at them because of the rules at our hospital with a lot of anger, we help them use the Just Like Me practice, which helps them see that there's more similarities with the person who's angry with you than dissimilarities, but also behind those hard feelings of anger are softer emotions, right? A sense of despair or sadness that they can't be with their loved one, and that there's some need not being met, like their need to provide protection, the need to be cared for, the need to be respected, the need to be heard. And then behind that is a universal need, such as the need to belong, the need to be loved, and the need to feel safe and secure. So this is a practice that has really helped. We've also, through meeting with teams, been able to enhance psychological safety, and psychological safety is crucial to the team adaptation to change. And so by making it safe for people to speak about their experience, we enhance psychological safety. And we also were able to enhance a leadership style that was based in attachment theory, whereby it's called socialized leadership, which can really help leaders be responsive, be perceived as being sensitive, and also supportive, even if the policies they need to enact are not what people want to be hearing. When you have leaders who lead from a place of socialized leadership, there's studies that have shown you have decreased burnout, increased job satisfaction, and increased sense of security amongst their employees. So this is my last slide, which is to really just remind us that, like Winston Churchill said, we have this choice. Are we seeing crisis as danger or opportunity? Are we looking at what we're doing as organization teams and individuals to respond and see possibility? And are we fostering resilience, post-traumatic growth, and taking stock of the lessons we're learning? What's better than what we were doing before? Some of the lectures that I've been able to drop into have been fantastic. The offerings have been really great. And to really, are we really working at making the system better through cohesion, trust, and a common sense of purpose? And to look at whatever policies are coming out through a lens of well-being. And so at our hospital, we've had someone represent staff well-being on all the planning committees, because we want to be able to see whatever is happening at an institution level, that there has been at least a lens of how is this going to impact the staff. And as our leader, our medical director said, we have to look after the feelings of the staff. So I'm going to end there. I'm sorry for keeping you late. Maybe we have time for a question or two.
Fantastic, Mary and Peter. So I've made a few notes here, some questions that were popping up in the Q&A and the chat area. So let me start off with this one. And it reminds me of a comment that was posted by someone who participated in our first webinar, who wrote about the loss and grief occurring in long-term care facilities, where very often the residents become like family members to the care providers, and the terrible losses being felt across the long-term care sector. And so there was a posting here that from someone working in long-term care, who I almost get a sense of feeling demoralized, providing the best possible care under very difficult circumstances, and still being painted, I guess, with that very almost shaming lens. Any comments or words?
I'd love to jump in there. I said that our team, one team I worked with, had a hard time being redeployed to long-term care, and over the course of just a few shifts being there, what became evident was this sense that really what it was about was they didn't feel efficacious in that system. And they actually, as they worked through it, came to fall in love with the residents and with the staff and with the system. The resiliency of the system. And what they said to me was, it was such a beautiful opportunity to learn from each other. We were learning from each other. At the same time, there were some very challenging situations. I met with one team that lost 7 patients over 5 days. Really, it was like losing multiple family members, because they knew not only the residents, but also the families of those residents, for those who had families. And even things like, even in working in that setting for a short time, what our staff said to me was they came to know what songs people like. They would sing to people. They really connected so closely. It's so essential to make space for the grief. And yet we're also told with the conditions right now, you know, there's not the usual rituals, not only the rituals outside of healthcare settings, but the rituals within healthcare settings. So one of our suggestions was to create new rituals for the staff, to really honor the stories of those people who have been lost, that it was important to take time to still have a ritual, even though it wasn't the same ritual as they were used to having.
Excellent, thank you. There was another very interesting question around leaders. So palliative care folks who are in leadership positions, such as unit managers, hospice managers, and a combination of, I guess, grief and outbursts that they're experiencing from family members who can't come and visit. And actually, myself and my team are experiencing something like that right now. Mm-hmm. Any words of wisdom?
I'm happy to take this, or Peter, do you want to? I work with this a lot as well.
Go for it, Mary. Thank you.
It's so challenging, right? This is a place of moral distress. So to really acknowledge that and to offer yourself that recognition that this is hard, and that I think everybody in hospital settings, hospice settings, home care settings are experiencing that, long-term care settings. And so to offer yourself, and this is where a Just Like Me practice is so important. It's like, just like me, this person wishes for the best care for the patient. And just like me, this person wants their loved one to be cared for with such love and compassion. And just like me, it's frustrating that coronavirus is here and has changed our way of being, right? It's not you that's changed it. And then to develop, again, we can work at a problem solving, from a problem solving point of view that's not perfect. So acknowledging it's not perfect, sharing with the person that you share their distress, sharing with them that the overarching principle is safety of all patients in the hospital. So it's not just about their loved one, which may be hard for them to hear. And to also offer that, you know, as much as they want, you know, there can be social media communication, virtual communication with their loved ones. I don't know what's happened at other hospitals, but they have made accessible to our patients iPads for people who don't have iPads. We've created systems where every time someone is going into the room with important information, they connect with the family. But some family members keep their iPads on a lot. Yeah. And so, and the last thing is we're actually just creating a handout about this, where we encourage people to also, you know, continue to do things together, listen to music together through virtual means, you know, watch a movie together if they're up to it through virtual means. So using virtual means to really help families connect.
Excellent. Some of the postings also, I think, are important to remind us that there are many in this boat of the stress as healthcare professionals, and the two postings remind me to really call this out. I think it's so important. Funeral directors and funeral staff work in funeral homes, and also paramedics. In our region, for example, paramedics have been providing fantastic frontline care, and they too are experiencing this. So I think that the thought occurred to me when the session becomes available as a recording online within a day or two, please forward it to as many people as you can, and including to colleagues that you may have connected with paramedics, or forward it in your region to paramedics, funeral staff, and obviously colleagues in your own services, and also within your own health organization that you work in. I'm definitely going to look at this again. I know time is up. I really appreciate that you responded to the questions that came through. There is an area of worry for me, though, and I want to highlight this. In monitoring the chat, it became evident that I think we also need to, each one of us, ask ourselves, do we need extra help? And to go get that help if it's required. I will own up, I get help as well. And I think it's important. You know, there's some people experiencing grief reactions and responses many years after the loss of a loved one, I see. Some people experiencing insomnia because of the stress of having to coordinate care even from home. So I would really encourage each one of you that posted that, and everyone else, if you are feeling that you are dealing with issues and need some help getting through them, please don't hesitate to seek help. Contact practice, your healthcare team, counselors that you're aware of. And I do know that in some provinces, some helplines are being made available. So what we might look is to go look and see if we can develop a list of these helplines for those folks who might be in situations where they don't have access to a team.
Yeah, I could help you with that, because CAMH, for example, has barrier-free accessibility for any healthcare workers to have a consultation, and they expedite it at this point, so a virtual consultation. And I breezed by that, so I'm so glad you highlighted that, because one of the functions that we do have in our CREATE program is we do triage. So when people tell us that they don't have, that they, you know, are having some symptoms that are impacting their functioning, then we triage them, and we have some services available at our hospital and through EAP, etc. But that is so crucial. that we each have as many types of resources to support us as possible.
Thank you. Thanks very much. So I'm going to ask participants across the country, because I know you're from across the country, if any of you are available of a similar helpline in your province, can you please share that with us by email? I think it's info@pallium.ca. Stephanie, if you can correct me, I think it is info@pallium.ca. Please send us those helplines. It'll help us create that list of resources. I think with that, Peter, any last words?
Thank you very much, José, for this opportunity. And I hope that the material I shared, and I'm open, as Mary suggested, Google me, and I'm happy to answer any questions or explore topics with people. Thank you very much.